So today's a day of first for me. This is my first Oley conference, and it's been a wonderful experience so far. I look forward to seeing you guys in coming years. This is also my first day actually as an attending in gastroenterology at Cincinnati Children's. Yesterday was my last day of training, and it's been a wild ride. I'm very excited. Thank you for having me here to talk about some of the research I did during my fellowship, and specifically on the effectiveness and safety of ethanol locks in the population of children with intestinal failure. So before I get started, who here has heard of ethanol locks? Can you raise your hand? Who either prescribes them or uses them? Okay, and who's never heard of ethanol locks? Okay, wonderful. So we'll start by there's no relevant financial relationships that either myself or my co-authors acknowledge, which leaves you to wonder which ones we didn't acknowledge. And so I'm going to start with a few definitions that everybody in this room already knows, but I'm going to go over them anyway. So we'll start with intestinal failure. And so clinically, we decide someone has intestinal failure when their intestine isn't able to support the nutrition and hydration needs of the body. There's many questions that come from this definition, and it can be different among different studies. For instance, is intestinal failure related to, or is it restricted to, only coming from certain etiologies, or can it happen with anything? It also doesn't really give you a time limit. So, surely a child that requires overnight IV hydration for a bout of acute gastroenteritis doesn't have intestinal failure, and yet they're using IV hydration to support something their intestine can't do that night. So is there a timeline in this? And when you look at different studies, and this is important to know because when people study this, they can be describing different things if they're defining that differently. And so there are variation in the studies, and so when you look at that, I would ask you to just pay close attention to how people describe the population that they're studying. For us, we defined it as anybody needing central venous access to support fluids, electrolytes, and nutrition for greater than or equal to 30 days. And so that's how you meet inclusion into our study and our intestinal rehabilitation registry from which the study was made. So the second thing that we'll talk about is bloodstream infections. And again, so people with an indwelling central line know about this very well, and this is something that's pretty scary. It's a serious risk for people with indwelling lines, and it's one of many potential serious risks with lines. They can basically occur for a variety of reasons. The two that we talk about is translocation, or bacteria crossing the mucosal lining of the intestine, and then the second reason is actually bacteria gaining entry into the bloodstream from the catheter itself. And we don't right now have a great way of determining the difference between the two when somebody comes in with a bloodstream infection. It's not ideal, at least. We can start with culturing the tip of the catheter, but that necessitates removal. You can do peripheral sticks, and you can imagine a pediatric gastroenterologist trying to convince children that have a central line to also go through the process of having a needle stick. Is not very fun, and it's not something that we like to do very often. And so the methods for distinguishing the two aren't necessarily ideal. We do know that having a central line, again, increases your risk of these infections, and we call them central line associated bloodstream infections, or CLABSIs. And these are, the reason we say it's associated is, again, because we haven't distinguished between the source of the infection coming from the gut or coming from the central line itself. We just know that there's bacteria in the blood. These are measured in events per 1,000 catheter days, and are distinguished from catheter-related bloodstream infections. CRBSIs occur when you know it's coming from the catheter. So how much of a problem is this? Again, all of you know this. It's a big problem. In inpatient pediatric units, with all like general inpatient pediatric units, the rates of infection are about 1/2 to 2 per 100,000 catheter, per 1,000 catheter days. And so this includes children with short-term central venous access for nutritional needs, oncology patients, children in the ICU. The rates are a lot higher in children with intestinal failure. There have been a couple studies a couple years ago that around the same time that this data on general inpatient units came out, that suggested there were somewhere between 8 and 10 infections per 1,000 catheter days. And there's a lot of proposals for why there's a difference there. And a lot of those proposals blame translocation. This is why I was making such a point of saying that we can't distinguish between the two. Because when you get an infection, a lot of people will tend to blame it on translocation. However, I think people that do it know caring for a central line is hard work. It's hard work on a daily basis, and it's hard work every day on a yearly basis. And so that potentially is also a source there, and is probably an under-recognized source of these bloodstream infections. The bacteria, when you think about it, in the lumen of that central line, they enjoy two things. They enjoy an environment rich in nutrition, right, because we're giving nutrition through this line. And the other thing they get is they get protection from all of the antimicrobial effects of the body or activities of the body. And so that's probably a pretty big source. There have been a couple of ways that have been thought about to address this. The first is the antimicrobial locking solutions. These are problems because this is a problem because they tend to be expensive. You have to use pretty high concentrations of antibiotic. And they also, at least, are thought to encourage the growth of resistant organisms. That's not something that you'd like to do. This is the molecular structure of vancomycin, just as an example. And then recently, people have started considering ethanol. It's cheap. It is antimicrobial. It kills bacteria, fungi, viruses. It doesn't care. It kills it. And it penetrates these biofilms that develop on the inside, these plaquey substances that protect the bacteria and allow them to kind of grow and colonize the inside of that line. And so ethanol locking, or the installation of ethanol into this lumen of the line and letting it sit there and disrupt the bacteria in the biofilms, was actually first examined in the pediatric oncology population as a treatment for central line infection. So when you knew that there were bacteria inside of that lumen, they could use ethanol and it would disrupt their growth. And that was quickly adopted by the intestinal failure population in order to prevent CLABSIs. And since this has begun, there have been several studies that have come out, a couple of which there were differences in these studies. And again, this gets back to why it's important to define the population that you're studying. So there are differences in the populations that were being studied, and so it's hard. And there were also differences in the percentages of ethanol used and things like that. So it's hard to make this generalization to a broader community. And so there was a study that came out. It was a meta-analysis, and for anybody that's not familiar with meta-analysis, it's basically taking a few or many imperfect studies and combining them to come up with hopefully a little bit better of a result, although that itself is imperfect because, again, you're taking imperfect studies. This is a figure from the meta-analysis just showing the 4 studies that they used, the results and the ranges that they found in those studies, and then combining them into this overall number. So the meta-analysis suggested using ethanol locks reduces the rate of CLABSIs by 7.7 infections per 1,000 catheter days. So that's huge. That's a dramatic change. But again, there's a little bit of a trouble here in generalizing this to the entire population, so continued study is warranted. The other thing that kind of came up from this is that there wasn't much of a description about the safety of ethanol use. Some have argued that using ethanol locks push you at higher risk for catheter occlusions. Others have argued that ethanol itself degrades the integrity of that central line and can result in breakages, perforations. So to address these concerns, we performed this study. We aim to describe both the effectiveness in our population, but also the safety of ethanol locks, looking specifically at perforation as well as occlusion. So we began with our intestinal rehabilitation registry, and this includes over 6 years of outcomes data on over 200 patients that we care for at our center. These patients are either enrolled at the time of diagnosis or on referral to our center. We prospectively collect a bunch of data points, including demographic information, lab values, the infection rates, admissions, a bunch of other things. And the registry itself is actually maintained by a database specialist. The purpose was to do studies like this, but also to improve the care that we're providing for our patients in our registry. There's a number of quality improvement projects that we do with this registry, and a couple of them are here. So we've reduced our CLABSI rate in our intestinal rehab registry. So this is over 200 patients with intestinal failure, now down to 1.3 infections per 1,000 catheter days. Huge shift from the 8 to 10 that was reported just a few years ago. And we've done that through a number of quality improvement projects, as well as the development of these multidisciplinary teams, so having many people involved in the care with individual specialties. The second one, and I'm sorry, there's a typo there, so we actually have reduced, so the percentage of our population in this registry with a conjugated bilirubin of 2 or less is 100%. That's one of the outcomes that we look at. That's a marker of liver disease. And so 100% of our patients in our registry don't have evidence of cholestasis or liver disease. That's one of the issues that comes with using parenteral nutrition. So using this registry, we compiled a list of people that were on Ethanol Locks. And throughout the time of the study, people were placed on Ethanol Locks for these following inclusion criteria, and were not allowed to be on Ethanol Locks using these exclusion criteria. So throughout this time, and actually over the 6 years of this study period, whenever someone had greater than 2 line infections in a 1-year period with a gram-negative enteric organism, they were considered for ethanol lock therapy. If they met any of these inclusion criteria, we considered them. The ultimate decision was at the hands of the primary gastroenterologist in talking with the patient, the patient's caregivers. So after the decision to start Ethanol Locks, we first determined the priming volume of the line that they had. So some common priming volumes are on the right side of the screen. These are the catheters that we use, the BARDs and Cook catheters of various sizes with their priming volumes on the right side. We educated the caregivers on how to perform Ethanol Locks, and then we scheduled dwell times. So for us, we used, and again, this was another thing with all the different studies that are out there, there are different dwell times that people have used. For our study, we used dwell times of 2 hours or more up to the entire length of the window. And we did dwells every day unless the patient condition precluded that. The caregivers then would follow just these steps that I've listed here, and we used 70% ethanol. This is probably the most commonly described concentration of ethanol in the literature. So what did our population look like that we studied? There were 30 patients in total that received Ethanol Locks at some point over the 4-year study period. The middle age or median age of patients was 6.5 years, although the range was huge. It went anywhere from patients at 1 year of age all the way up to 20 years of age that were in our study. And there were diverse etiologies as far as the intestinal failure that were represented in our population. A closer look at this reveals there are many causes of short bowel syndrome, several causes of pseudoobstruction, and several children requiring ongoing central venous access for support after multivisceral transplant. The inclusion of the last group may be a little bit controversial, but we would argue that they still require central venous access, and that still puts them at risk, and so we've included them in the study. So the study group, the experience of the study group totaled over 23,000 catheter days, divided into almost 9,000 days off of Ethanol Locks and 14,000 days on Ethanol Locks. Just an important aside, we don't use ethanol in PICC lines, just due to their composition, and there's really a paucity of data in using it in PICCs. And so from our database, we pulled information about outcomes regarding infections and line complications, and then divided it by time on and time off of Ethanol Locks in each patient. So in that way, each patient acted as their own control. So we got to compare what an individual patient did while on and when off. That's important because each patient probably has different specific factors that kind of go into whether or not they're going to get an infection, how they're cared for at home, things like that. We next analyzed this data using a statistics technique called Poisson mixed effect regression modeling, which is just fun to say, but also allows us to model the infections and adjust for things like age and gender. And so we found a significantly lower rate of central line associated bloodstream infections with Ethanol Locks, so during time on Ethanol Locks as compared to the time off of Ethanol Locks. The CLABSI rates were relatively low to start at 5.53, but decreased to 3.14 infections per 1,000 catheter days with the use of ethanol locks. So this is probably about 1 infection per year that we brought it down to. And you may be thinking, well, he just told us that his population is doing so well with 1.3 infections per 1,000 catheter days. And just recall that the inclusion criteria was already that these kids are having multiple infections. So this is really the high-risk group that we're looking at, and that's why their infection rates are a little higher. So we looked at the bacteria causing these CLABSIs, and we found that there was a decrease in all types of bacteria, gram-positives, gram-negatives, and polymicrobial infections. There was one occurrence of a fungal infection with ethanol locks compared to none when off of ethanol locks. We don't think that the ethanol caused the fungal infection. I think it just happened while the patient was on ethanol. Also of note, the most common organism that we recovered both on and off ethanol locks was Klebsiella pneumonia. So after confirming what essentially others have found and described, that ethanol locks reduces the risk of central line-associated bloodstream infections, we again looked at safety. And so we actually found a lower perforation or breakage rate when on ethanol locks compared to when off ethanol locks. Further, we found that the incidence of occlusions was smaller but not statistically different, and certainly not larger when using ethanol locks as compared to when off of ethanol locks. Just a note on this, we don't think that the ethanol actually strengthened the lines. We think that by the time that these patients were placed onto ethanol locks, they were in a high-risk category. They were giving special instructions for how to use the ethanol locks, and probably the overall care of the line improved through that, and that's probably why there was a reduction there. The important thing, though, to know is that, at least in our view, and this is, I think, the largest study so far in pediatric intestinal failure of ethanol locks, it did not increase the risk of these complications. So we concluded that ethanol locks is safe. Ethanol lock therapy is safe and effective for reducing CLABSIs in the pediatric intestinal failure population. We take these data and indicate that lower CLABSI rates are possible with great line care, and that the true risk of CLABSIs due to this translocation is pretty low. Again, remember, we've reduced our line infection rates to 1.3, not through changing anything that we were doing with mucosal barrier function or how the lining of that intestine functions, but really just through improved and really diligent line care, educating both outpatient caregivers as well as the inpatient teams and how to appropriately care for these lines. In the future, there's a couple things that I just wanted to end on. I think it's going to be important to be able to distinguish in a non-invasive way the difference between translocation events and then infections that come from the catheter. There's a lot of mounting evidence that the microbiome plays a huge role in growth. And I think we need to really determine how antimicrobial exposure changes one's ability to grow, and how we can better balance our dependence on broad-spectrum antibiotics in the setting of possible negative effects. And then finally, and I think actually this is probably the most important thing, we need to create some kind of collaborative improvement network created and tasked to perfecting and disseminating these and other methods for improving care for children with intestinal failure. There's a couple examples out there, the most salient of which is the Improve Care Now network, which has led to dramatic improvements in the care for children with inflammatory bowel disease. And I hope one day we can have some kind of network like that, where we're able to really raise the bar for everybody through basically obtaining data from each and every patient encounter, to be able to again raise that care bar for everybody across the nation. So I just want to thank the Oley Foundation for everything, for the opportunity to present this work, for supporting progress towards improvements in home PN. I'd like to thank my team, the intestinal rehab team. This is a current picture of them. It's a huge group. I want to thank my mentors that are on the right side, Dr. Kokocius and Dr. Cole, who have welcomed me into their division. Again, today's my first day, so I'm very excited to start. And be happy to answer any questions. I brought actually some handouts. I only printed 30, and I'm sorry about that. If anybody else wants one, I'm happy to send electronic copies.
Well, we are going to open this point now. I just want to make one point, and that is that all physicians at least know that we use alcohol to clot and stop the bleeding in varices, whether they're pharyngeal or rectal. So there's been a lot of concern about using 70% alcohol, which is a very high concentration, in central lines because of the potential risk of some of this getting into the system. So my question to you, because I noticed in your paper that you didn't always deal with lines that you had put in. So how comfortable are you with actually knowing the exact volume and therefore the amount that you can safely put in when you do that?
It's a great question, and most of the line manufacturers actually give you a priming volume for the line. But what you may be getting at is, so that's a perfect world, right, where you have the exact line that was put in at the time, you know, and that's it. But actually in the real world, things happen to those lines. They get fixed, different legs are added, they're shortened, and so we don't know. We have some other kind of ideas as far as what the extra priming volume is for additional legs that are added. We sometimes will subtract a little bit from if a line is significantly shortened, but most of the time we use the same priming volume, and so a little bit does probably enter the bloodstream. We've not seen any change in liver enzymes because of that.
All right, are there other questions that people would like to ask? Yeah. You want this microphone? This is the fellow from Australia.
So two questions. So firstly, thanks. That was a great presentation, particularly topical for me because my daughter is 4.5 years older, and we're just considering some sort of ethanol lock in Australia. She hasn't had an infection, although apparently the second I left Australia now she got an infection, but it's under control. But she's been 2.5 years without. Now your study, the participants already had sort of higher infection rates. In terms of like really high, purely preventative, what are your thoughts on, if it ain't broke, don't fix? If we're 2.5 years without, okay, so we got one now. Do you rock the boat and try something different? My thoughts are there's got to be something building up in the line. It can't hurt to try and clean it.
Yeah, and I think that's, that was one of the reasons for our inclusion criteria requiring actually that there would be a few infections before we consider starting ethanol locks. Certainly in the case of a fungal infection, those are really hard to clear. And so in that case, we would start right away with the first infection. In terms of bacteria, again, this is a registry of over 200 patients. 30 of them met our inclusion criteria. Most of the other ones aren't really getting many infections. And so, like you said, I think while it's okay, it's safe, it's effective. If it ain't broke, don't fix it. And if there's a few more infections, then probably start thinking about it. You guys know this. This is all about weighing risk and benefit. And this adds, on top of all of the other things that we just talked about, this adds another several steps every day that you're doing. And so probably one infection in 2.5 years, that's great.
You can do it on an irregular basis. So I guess, obviously your study didn't sort of factor that in, but maybe once per week, or that's also possible, correct?
It's possible. I don't know how effective that will be. So the idea is that the ongoing exposure of ethanol is going to disrupt the biofilms over time. It doesn't necessarily just kind of happen like that.
Just on that note, a very short part of the question. You mentioned that the ethanol penetrates the biofilm. Mm-hmm. My understanding from various discussions with various professionals is that you cannot penetrate the biofilm. Alcohol does not penetrate the biofilm. Is that a...
No, I believe there's some evidence actually that where people have done this, and this isn't in this is in vivo, so the lines are actually not in use, but they'll put biofilms in the lines and then use ethanol, and they do see that it's
the biofilm continues to exist. It just can penetrate. Is that the...
Well, the ethanol can disrupt the biofilm and break it up so that it does end up killing the bacteria. As far as the time to do that, I think that's going to depend on an individual basis. I don't think you can necessarily say, oh, it'll take an hour and it'll do that, or...
Interesting. All right, thank you.
Other questions? Dr. Darlene. I'll have this one.
Two really quick questions, and one may have been my inattention. Was this a combination of inpatients and outpatients? Have you separated those two groups? Because in general, outpatients do much better than inpatients in their infection number. The other quick question is, or comment, in Europe they're using a lot of Taroladeane, which is not yet approved here. And it would be interesting if you could get an IND and compare the Taroladeane and the alcohol.
Yeah.
Thanks.
We had, you're right. Taroladeane is also something that's been used, and I think that, eventually, again, so this gets back to my hope for the future. What?
We've only got 7 minutes left.
Okay, this gets back to my hope for the future, that there is some network where we'll be able to do these things, because this is an orphan disease process. There are not many patients at each individual center, and it's very hard to study this and to be able to say effectively this works or this doesn't. And so I don't think that you'd be able to determine any meaningful relationship there, or superiority of one versus the other, unless you were able to study it across multiple centers. And if you did that, you'd have to have the same definitions at each center.